Welcome to Tactical Scrubs, another beautiful episode. We are back. We took a little hiatus. We've been working on some really cool projects. So I'm excited to have with us today Miss Kim Urbanek. I'm definitely a fan. I read Kim's book years ago when it came out. Marketed by CPI, but it's actually Kim Urbanek and her beautiful, wonderful thoughts and her just process of what she's developed to make a security department successful. So really excited to have you here with us today, Kim.
Welcome to Tactical Scrubs, where healthcare meets frontline strategy. Today, we're joined by Kimberly Urbanek. Be sure to like, comment, and subscribe for more valuable content from us. As always, thanks for listening.
Thanks for having me. It's exciting to be in the Tactical Scrubs studio. So happy to be with you and Dean.
It's a crazy time. Yeah, Dean is here as always, trying to keep us on track. So it'll be good because anytime
trying and failing.
Someone needs to. Someone needs to lay down the law.
Yeah, and the audience deserve the truth. This hiatus is purely just an issue about a Spotify password, Mel. Let's peel back the curtain. We have episodes ready to go, but somehow we just haven't been able to navigate that between us. So this hiatus, I'll take full responsibility.
Forgot your password. Your password.
I can't even unlock my iPhone to refill my Starbucks card most of the time. So the password, if anybody wants to steal my Starbucks, is always some version of password and then a number.
It's the number that gets you, I'm sure of it.
The problem is I can't ever remember the number.
Yeah. So I'll take full responsibility. So, happy to wear that. It's a heavy burden sometimes.
We were just waiting for better content. We all begged Kim Urbanek
to
get on here and help us. No, but
that is the truth. Yeah, that's true.
So everybody tell Kim, tell everybody kind of maybe a little bit about your journey, how you got into security, because I think people know that you're definitely a thought leader in this space, but probably a lot of people don't know where you came from or how you got here into this level of kind of expertise.
Well, thanks. I don't know that I can take quite all of that, but I appreciate it. I think healthcare has been a calling for me forever. Since I was little, I was contemplating med school. I was dissecting fish whenever I went fishing with my dad, and looking at the internal organs and all of that thing. So I've always really been drawn to science and drawn to how things work and fixing things, and especially under pressure and under crisis. And that was kind of how my journey started. I started in healthcare and I started clinically, which is, I think, a really non-traditional route for most, professional security executives or security leaders. So I started in critical care and open heart surgery. Did that for multiple years. And although I learned a ton and loved it, I was like, it's kind of tame. It's very controlled.
Yep.
And I wanted to go where the action was. And so, of course, that led me to the ER, which is kind of where I always had my sights set. And I worked in the ER for many years. That's the majority of my clinical background. In addition to working for a healthcare facility, I also, prior to, my escalation here, I was a critical care paramedic. And so I worked for the fire department and did EMS and 911 and flight medic for a little bit. So kind of made the rounds in all of that first responder emergency management kind of piece.
And that shows through in like your ability to connect the community to a hospital. Like I think a lot of people that come from the policing world into healthcare security aren't as great as connecting to the outside network and the people that are bringing your patients in. And I think you, because of your paramedic background, you've done a really good job at creating collaboration across systems and in between community organizations.
Thank you. I think that I can bring a unique perspective being kind of on the interior inpatient side or the ED side, like the behind the scenes healthcare, and then that pre-hospital kind of chaos inside. My whole family comes from either law enforcement or healthcare. So I've kind of married those two apparently in my career path. a little bit unintentionally. But when we had some leadership changes and some big schedule changes, I ended up transitioning from part-time in the 911 world and full-time at the hospital. I switched those. So I went full-time at a department and part-time in the hospital, and ended up transitioning into security. So I was already very familiar with our guys and our team, and they were partners in what we did every day in the emergency room. And we had to work collaboratively. And so I was already then starting to teach. I've always liked teaching or trying to better myself and improve. I'm forever a student. I think that's probably one of the ideal jobs if someone would pay me lots of money to just forever go and learn all sorts of fun stuff. But I really started training our officers. I think we lost you. We don't have your audio.
Look at me.
There you go.
Computer's freezing. I told you. I tried to kick my kid off Fortnite, but I'm gonna have to figure that out, But
It didn't work.
Fight.
It didn't work.
That's where we need Kim's security expertise,
Right?
really, to come and run a household.
A bouncer.
Yeah,
it's just a bouncer.
Is it time for school? No, I'm just kidding. But I think that's that the best security directors that I've seen are the ones that are great teachers, because you're taking the things that you're seeing in the reviews and the incidents and all of the executive meetings that you're coming from, and then you're trickling that down into your department and being able to kind of change the dynamic, because I think people in security get confused about what the real asset is, like we were talking about earlier today. It's like, is the asset the patient and the nurse? I think in healthcare security, the asset is the relationship between the patient and the nurse. And that's what keeps everybody safe, or the patient and the caregiver. And so security, a lot of times people are like, oh, just throw that on security. That's security's job. Security will fix that if we have an incident. But in reality, it's training, it's understanding the dynamic, and it's protecting the relationship that exists between the caregiver and the patient. And I think, Kim, as exemplified in your book and the other projects that you're working on, you kind of show what it looks like to be a director, but also a director that cares truly about the asset.
I appreciate that. The training aspect is extremely important to me, especially in the training transfer. None of it means anything if it doesn't work, if it's not applicable in our daily work, our daily lives, if I can't see a practical approach or how to connect what I've learned in a book or in a classroom or on an online module to actually translating that to something that's going to be effective. So that was always an area of focus for me. And I started really our public safety training program, and just new hires and learning some of the laws and some of the limitations, and, bringing concepts like EMTALA in and certain things like that no one was talking to security about, or security didn't have an understanding of, worked to professionalize the role a bit. I didn't want my name attached to something that was going to be crappy. If I was going to do it, I wanted us to have a good reputation. And I will say that that's questionable initially, at least, or at a lot of organizations where I'm doing consulting and stuff now, and where you see there isn't that connection and that relationship. So I like what you said. I'll go one step further. The integrity of the relationship between public safety and the clinicians or the healthcare providers, right? So that's the triangle. So yes, the relationship between security and the patients or family, the healthcare giver, the clinician, and the patients and family. But that missing piece is the connection and the partnership between the clinicians and the security officers or public safety. And that is the piece I think I've been able to help bridge.
Yeah. So to clarify for people that are more clinical that are listening to this.
Sure.
Public safety is really anybody that's in the demographic that feeds the patients that come into your hospital, whether that's EMS, whether that's fire, whether that's police, that's dispatch, that's, and, in the US, it works a little bit differently than the UK where Dean's from because, we're newer. I'm just kidding. We're newer, we're shinier. But we also have a federalist and states-based society, so we have different regulations, and sometimes those regulations overlap, and that's been one of the main reasons why I've kind of started learning a little bit about just legislation and law and how does this all fit together. Because for instance, these body cams, it's the first time people are using body cams in clinical environments. So there are no laws that talk about what that looks like. And does it comply with CCTV, or does it comply with, your ability to provide care and not cause a problem with your ethics that you have as a nurse and the things that you've taken as a paramedic or your oath. And I think that's pretty interesting to look to some of the research that exists in other countries, which is why when we're looking at doing projects like we're looking at doing with the Institute of Homeland, like how can we get data? Where do we get the data from? And, what's good to measure in the US because it's so unique. It's not like any other country, and the for-profit health system is different than a lot of other areas where they're able to get data accumulation a little bit easier because they have a more broad sense of healthcare, whether you're looking at Canada or the NHS or areas like that. So it does make it more challenging for us, but I refuse to believe that it's impossible and that we just dismiss it. And that's kind of why, Kim, I love working with you because you're like me. You're like, okay, let's figure it out. Let's find a way, because you've done that. So talk maybe a little bit about the things that you've seen in your department now, your regular day job. Kim does many things. Let's just start there. Kim has this incredible new platform, Dean. This thing, I did a review of it for her, and I was so honored. I'm like such a fangirl. I'm like reading Kim's stuff at night shift while I'm trying to keep patients in the bed. Like some days we wouldn't have enough sitters, so I would sit and I'd pull out Kim Urbanek's workplace violence book, and I'm reading it, right? And so
you're a source of information, though. You're really good about absorbing all of the great stuff. So
because I was on night shift trying to keep people in bed because we didn't have no sitters, okay, for all these psych patients. So really, I was just mad that I had to sit there. I was just motivated by passion. I'm like, this is not what I want to be doing right now.
No flip-flops and the sitting service. It's a different skill set required, isn't it, entirely?
You know what?
Can't throw those. You just can't throw them at people.
I can throw them around corners. I don't think anybody would be able to see. And as a Baltimore City ICU nurse, I'm sure there's plenty of gang members who remember me closing that curtain and having a very strong conversation about how we were and weren't going to speak to one another. So I used to be one of those instigators. And then I went on this journey. And I got to work with
this is where the therapy begins. There we go. See, I promised that we'd reach this point where, 13 minutes in, Kim, make a timestamp of this, please.
So I have to say that, I love Mel. I love working with both of you. And at one point, Mel has fully embraced that transition from clinical to security, public safety role. But at one point, she was one of those nurses that the public safety teams were like, what the heck are you doing? Knock it off. Because we're going in to save your butt. We're getting our butts kicked because we're going.
Can't imagine that one moment. The same Mel Cortez that joins us now on this podcast. Are we talking about the same? I can't relate that story.
Little
Kim, whatsoever.
Fiery personality here.
The only difference between me then and now is that I learned how to actually fight. Muay Thai or whatever.
Good. We can all rest easy in that knowledge then. So, if I can go back slightly, Mel, to something Kim said about 5 minutes ago. We were you actually introduced the idea about the relationship. You may have seen it, Kim. You might not. If you haven't, I'll send it. But just over a decade ago, the NHS produced a document about relational security called See, Think, Act. And it's designed mostly for what we call forensic mental health hospitals. So that's where we have the technical language is mentally disordered offender, but really we're talking about where someone has a criminal history plus a mental health condition, and it's decided that the mental health condition takes priority. So they go to either a low, medium, or high secure service. And the NHS is very good in lots of ways that you wouldn't expect. And one of the ways it's often good is that every now and then it produces a piece of guidance that is almost like it never gets updated because it was just so good originally. And this is one of those documents. And I think that there's great scope for taking some key elements of that, and it can be applied in lots of different settings. So if you haven't seen it, I'd be happy to send it. But if you have seen it, I just wondered if any of those concepts had translated to your experience where you are.
I will say it's good to see the industry evolve. And when you have a piece of documentation like you're speaking about that is so good and so basic and fundamental and essential that it just, transitions across all time, then that's a must do. We know that's a best practice. And so we need to do, I think, a better job of looking at best practices cross intersectionally, right? Where, they're starting to do that now. They look at healthcare as a business. We've never operated healthcare as a business before, allegedly. And, we have to look at bottom lines and all of those kinds of things. But we do have to be innovative in healthcare now and reintroduce things and creative about the way we reinvent how we're providing care with all of the challenges that exist. And so when we're looking across other industries, go ahead. We can't hear you. You're muted.
My computer is so slow. I mean, you mean challenges between one yacht and two yachts, right? Like, which one are we doing?
Do you know how much it costs to insure a yacht? I think we should go easy on people like that. I mean, it's really expensive now.
Oh my God. Or the operational costs of 13.
Exactly. Like the price of fuel these days.
2 private jets,
Yeah.
That's right. Expensive.
Yeah, healthcare's definitely never been operated as a business before.
I think you're right, Kim.
Yeah, I agree, Kim. I agree.
So just to kind of finish that thought, I think where there are best practices that are already established, let's not reinvent the wheel. Let's look at how it applies in our setting. Yeah, different setting. Yeah, pre-hospital, in-hospital, emergency room, outpatient, inpatient. But the fundamentals, the basics are there, and we have to build on them. And so healthcare is a relatively new industry in the structured, formal format that it's in comparison to so many other, right? So we have to still be willing to learn.
Definitely. No one was more surprised than us over in the UK when this document came out, because it was completely unexpected, because it made sense. It was rooted in reality. It was almost universally applicable, and you could implement it without spending great expense of time, or you didn't need an IT project that had been centrally contracted for hundreds of millions of pounds. I mean, it was, and I feel to its, perhaps it's a victim of its own success, that it's kind of just almost been forgotten about. Like when I was teaching at Nottingham Trent University a couple of years ago, it was almost too old to be presented, but actually there was nothing newer or better. So I think it almost needs, even if someone just looks at it and changes a bit of language and calls it version 2.
Outdated,
right?
Still valid.
That's him telling me what to do. Do you hear that? If someone would just look at it and, make it better or something and adopt it for the American market and then find somebody to try it, that's just
I don't mind. Yeah, I don't mind if you just do it for the UK market. I mean, I don't mind if it's in English. I'll find a way to use it. The borders don't stop me, as you've seen recently.
Self-serving.
Yeah. I'll send it across. But I suppose this was a long-winded way of saying, if you haven't seen it, I'd really be interested in your thoughts. So if I send it to you and it pops into your email, this was kind of the conversation and reason why. And I don't mind if you hate it, because I think that will be thought-provoking as well. So I didn't write it. So
now I'm nervous to hate it. Now I can't hate it, right?
Well, though it's in a fire, cabinet, comes, it's gold encrusted. Oh, you'll love it. All the stuff we took from the British Museum, we put in that document. It was the last great thing we
Oh
did as a
boy.
nation.
No. Kim, I think this is a testament to like people just value your opinion. Like I think people are always reaching out for, what's Kim's next insight? What does Kim say about this? And I think, that's what we need in this space, because we do need to keep learning and we need to keep innovating and we need to keep changing. And Kim's always been the type, like when we're talking about her book, she's like, oh yeah, well that's like the first version and I'm sure I'm gonna have to edit it and do more things and blah blah blah. I'm like, it's like liquid gold, it's so good. Like I think that type of mentality makes her a really strong leader. I think one of the things that Dean really enjoys is working with executives, like C-suite executives, and helping them to position themselves in a place where they can be as impactful and as powerful as someone like him. So it's good to see those leadership skills develop. And I think in a hospital where security is oftentimes very siloed, it is difficult to get people to listen to you or get people to buy in. And I think understanding clinical applications and finance and the business of healthcare is really important for a director to kind of wave your flag and be like, hey, we need some resources or we need help over here, and this is why.
I think that's such a key point that you bring up, because everybody's so siloed, right? So I will say, from the perspective of security, public safety, you're non-revenue producing. So overall, people don't want to hear you or don't necessarily feel that you have a lot of value when you're asking for budget, when you're asking for proactive things. Your return on investment, at least I'm talking in the past, was questionable in a lot of executive minds. And you almost just checked a box. At least that was a lot of predominant approaches or mentality around what it was. And you were the heavy, right? We only call you when it really hits the fan, and just come in and straighten it up. And so I think with organizations that, professionalize the industry, right? Like NHS or IAHSS and as is, and a lot of those professional, even security organizations are saying, no, that's not enough. This is more complex than that. You're not the bouncer at the bar down the street, or even coming from a law enforcement background where it was believed that the best executives in healthcare security are only from law enforcement. They've got to know it all. And I have great numbers of colleagues who come from that world and have made the transition extremely well. But they're like, wow, I had no idea.
Yep. If you talk to them, that's the first thing that they say is, oh my God, it is not law enforcement. And anybody who goes into it thinking it's law enforcement is in for a very rude awakening. And I think that's been my whole goal, is like, okay, I saw these experts that I learned a ton from, you, Dave, Paul, Eric, all the really kind of impactful people, even on the tech side, like a Rachel Nolan and people like that, who are just really knowledgeable in this space. And I was like, oh, these are this is its own professional area. Like, why are we not buying and investing this? And then I found the profitability portion. It's like, okay, well, if you look at Maslow's hierarchies of needs, safety, physical safety is a core component of that. And without that, you're not able to access any upper level thinking. So if you're asking nurses to critically think through their day, or healthcare workers to make big complex decisions, they can't if they're fearing for their safety. So then you've got retention, you've got recruitment, you've got quality issues, and that's where you see security really making a return on investment, because the rest of your operations depend on that. And that's something that, when I started reaching out and talking to experts and bringing people into the space like Dean, I trust his executive level operations as not being security, but understanding the importance of security from working in those high secure environments.
I think you just have to be receptive to all aspects because it is a multi-departmental, a multi-approach, a cross-section of involved individuals, people who are going to school for many, many years to receive a license to practice versus somebody that's like, okay, I'm looking for a summer job and I want an entry-level position somewhere. And so it has to fall somewhere between there. And I think you'll find still both ends of the spectrum, but in healthcare now, with
It's too dangerous. It's too
especially
dangerous.
the statistics of workplace violence, especially with the regulatory requirements with your agencies and the prescriptive way that they are now enforcing regulations or compliance, some random person with no experience off the street often is not your go-to person if they don't have a world of experiential good communication, even going into my nursing training. So that's one of the other pieces I think that has made our program really successful and robust is that we don't just do public safety training, right? That training is for everyone in the organization. And there's levels. It's based on risk. It's based on exposure. It's based on vulnerability. It's based on your base knowledge. And so we've incorporated training on aggression, training on, something aggression is going to be basic communication and the brain science behind escalation and how to not take it personally when you're on your third 12 and you're understaffed and you've got to pee and you haven't eaten and you're a bit hangry and somebody, and you're dealing with family members that are some of the most, challenging moments, who are in their most challenging moments. Okay, how do you step back and still understand you're the baseline right now of whether this is going to escalate or not? Right?
Yeah, and I think
This is a powder keg. And if
it's
we're
hard.
not incorporating them into that training program, then we're missing huge opportunities. And so it's extended well past the security department. It has to.
I think that's the biggest piece that I've learned from working with people in the UK. They have this training standard that, and now that my concern is that the technology is entering the space before the training has been able to catch up. So now we're putting things in like body cams and we're seeing what's going on without being able to have the right training for these nurses. And so previously, since physical restraint training and compliance training and things like that were only on security, now you have nurses who are, because of policy and procedure, security isn't doing those things anymore because people are watching and they're wearing cams and we can't do this anymore and it's too much of a liability. So then the nurses are now tasked with it when they have no minimum standard of training or no minimum. We don't learn that in school. And even now, these schools are really reluctant to teach it. I talk to a lot of deans of different, because I enjoy lecturing to like nursing students, right? And so when I talk to these deans, they're like, well, how are you supposed to talk about workplace violence without making them not want to join the university? And then they're just going to go home and leave. I'm like, they have TikTok. Like, they're watching what's going on. They're like, they are watching they already know, and they're still signing up. Like, these are the heroes, not me, who wore a trash bag. Like, these guys who are like, oh, it's fine to get, to deal with this. So I think we owe it to them to tell them the truth in a way that makes them feel like they can be part of the solution, like your training, your positive communication skills, and also understanding personalities. There's no seasoned nurses. I was just talking about this with Dean. Patricia Brenner, the nursing theorist, has a theory that you don't have an experienced nurse until 5 years of nursing. 40% of new graduate nurses are leaving within the first 2 years. So they're not even getting to competency stage. So you've got nurses that are becoming charge nurses after 6 months. And then you're wondering why they're stressed and they're panicked. Well, you've got patients that are in fight or flight mode who see that the nurse is in fight or flight mode. Who is holding the form here? Nobody. There's nobody that we can go to and be like, hey, how do I deal with this? Or, hey, can you help me with this? Because they just don't exist because they haven't seen this stuff before.
Yeah, I think what you're calling out is the huge need in the diversity of training that is offered or provided, the diversity of who is involved in creating it, in learning it, in executing solutions for it. You know, some of the basic training that people get, like you said, restraint training, competency training, use of force or self-defense, or maybe some sort of de-escalation module, MOAB or CPI or something like that. But we have to look at, I'll go back to basics, right? The 4 types of violence. We know we have criminal violence. We know we have patient generated or family generated violence. We also have employee on employee violence. Let's talk about that. How come nobody's training on that? You know, that's an HR requirement and it's part of your, handbook or your conduct, your standards of conduct. You know, if you do something bad, then it's not allowed. But nobody's actually talking about that. Your domestic violence that is spilling over. And I talk about and train on how healthcare, domestic violence in healthcare, although it's not the most voluminous, right? It's not what we're seeing most often. Patient generated is, but it's the most fatal.
It's
It
the
is
most deadly.
absolutely the most deadly. And we have 2 forms of it. Anytime you talk to a healthcare worker about domestic violence in the workplace, they say, oh, that means that the caregiver of my patient or the father of the mom that's in labor and delivery. And we're like, no. When you talk to any other industry about domestic violence in the workplace, they get what that means. That means domestic violence of actual employees that's spilling over, partnerships or relationships of employees spilling over. And when you just look at the sheer number of statistics around that, right? 1 in 3 women is involved at some point in their life in a serious physical, domestically violent situation.
Hospital security saved my life. My first husband was very violent. And when I was young, I was a brand new young nurse. I was 20 years old, 21 years old when I was pregnant with my first son. And he was extremely violent. And if hospital security, it was a paramedic who told hospital security what was happening to me. And they started escorting me to and from my car. And they would see him out there waiting for me and they're the ones that were like, you should probably, this isn't right, you should get help. Like, they're the ones that told me. And I really, because when you're in it, like, who would know? Melissa, me, Mel Cortez, someone's beating up Mel Cortez. Like, that's not a plausible, real plausible situation. But I was a much different person then. I was very young and, it was a different time in my life. And so it was actually hospital security that intervened. And I was like, hey, this is maybe not, this is out of control. This is escalated to the point where other people are concerned about me and are taking care of my welfare and well-being. And I'm really grateful. And I oftentimes tell that story because I think it's important for security directors and regular just general officers to understand the impact that they could have if they see something, and being able to have because I wouldn't be here today if they hadn't said something. So I'm very, very grateful. And I think it's a great point that we need to start talking about more. And I think Dean has some interesting insights when I'm telling him, like, these are the stories or these are the things that I'm seeing, and it has a lot to do with our labor laws in the US. Our nursing labor laws are not very strong, and there's some legislation that definitely we have room to go with being able to protect nurses. There's a lot of at-will states here in the US, and since organizations are very much business oriented, they really want to have the pathway of least resistance as they move forward. And unfortunately, that culture has kind of been passed down where nurses become leaders or other department heads become executives because of tenure and not necessarily because of training. So dealing with some of these situations where bullying is happening or the lateral violence is happening, they're not exactly sure how to deal with it. So they're not sure what to do. And then what do? Fire staff when you don't have staff to work? Like, it's a very difficult situation to work when you're in such a staffing crisis. But that's the importance of leveraging culture. And it sometimes has to get uglier before it gets better,
So I love that you bring that up. It made me think of something similar, or at least I see the correlation is really having the integrity to stand behind what you say you stand for. And I see it regularly when we say, well, you don't have to take this behavior. We're all about staff wellness now. If a family member is doing something bad and we've done everything that we can, of course we want family to be present, but if it's not feasible because of the risk, then we can't do it. And then you add in a complexity like, well, the patient might be terminal, or well, they're in hospice, or well, and then all of that culture and empowerment and like, yeah, we stand with you is like, is there something more we can do? And everybody instantly recoils and backs up. And that mixed messaging is felt. And once that happens, you've lost all trust.
Yeah.
And you've lost validity.
Yeah, we had that when I first came into the sector in the UK. That was very much the case. It was almost like the approach to being injured or assaulted at work was similar to like the old policy in the US military of don't ask, don't tell. Yeah. And
interesting. Yeah.
That started to shift. So it was kind of this thing that everyone acknowledged was real. There was a varying viewpoint about whether it was okay or not. But it didn't really matter because you weren't allowed to talk about it outside of the confines of the shift and the staff room and whatever. And then there was a shift. By the time I'd become a registered nurse and then moved into management, there'd been a shift and it was driven from the grassroots level, where it was just like, yeah, actually, we're just going to use the laws that exist and we're going to report stuff. And we adopted the approach of it's not what you preach, it's what you tolerate. And there's a great culture in the UK of, because our labour law is stronger, and so in the UK, for example, if you don't whistleblow about something, you take the personal responsibility for that. So you're always thinking, well, I might lose my job at this employer, but I'll lose my profession if I don't. So in our minds, it's always very clear. There's nothing more important than patient safety. Our regulatory body emphasizes that. If you whistleblow and it's a legitimate case, you are legally protected. So
and
even if
that's not the case for nurses because they're at will.
So, and also I agree with what you said, but I want to add, you cannot have true patient safety if you don't have staff safety.
Yes, yeah,
because they're interlinked.
Yeah,
right.
There's no.
I mean, if I don't feel safe, I'm not answering the call light. If I don't feel safe, I'm not coming into your room. If I don't feel safe, I'm not interested in accommodating you in some other way. And that maybe that's not a popular thing to say, because I'm not trying to question the integrity of any nurse anywhere. But the reality is, and even in public safety, it's not just nursing, right? It's every human. Mm-hmm. I'm going to be more avoidant, and more is going to fall through, and you're going to fall out of the bed, or you're going to miss a medication or have a delay. And finally, they're starting to do some research on that. But, I could have probably told them that over 15 years ago.
Anecdotally, we all knew, right? Because again, it's never what you preach, it's what you tolerate as a professional body or as a group of employees or whatever. And I think people have to take the ownership to just be smarter than the previous generations. And I mean that respectfully. Like, we need to take the learning that's been handed down. So one of the great arguments, I'll use mental health. So in a mental health service, there's lots of violence, it is part of it's the coinage of our realm. Risk is the coinage of our realm. That is the treatment. That is the therapy. That is why we exist, for the most part, in an inpatient mental health setting.
True.
So violence is very much a currency used within that. So it's very common on a shift to have multiple uses of force, violence, things like that. There are some settings where it rarely happens. There are other settings where you might have 20 episodes of it per shift, per day. And there's a whole host of stuff in between. And so you're in a position where you have someone who's assaulted a staff member, In UK law, that means a crime has been committed. But people would never report it. So we have a great culture of incident reporting, but we had a really poor culture of criminal reporting. And this was the way, certainly when I came into the sector, again, don't ask, don't tell. Managers wouldn't ask if they wanted the police to be informed, and they'd hope that the employee never did. And when I remember asking the question, like, hang on, this doesn't seem just. We're big on just cultures in the UK. It doesn't seem just. This doesn't seem right. Oh, well, they're mentally unwell. And it took me a few years to kind of think, what's the smart way to dismantle that argument? And I couldn't figure it out. It took me ages. I went to nursing school, became a nurse, became a manager. And then I think I figured it out. Because at the same time, we talked about destigmatizing mental illness.
Mm-hmm.
So I said, it's not very destigmatizing if you say there's a group of people that are outside the rule of law and that the law has to apply equally to everyone, because otherwise you have a separate and unequal policy. And we've said constitutionally across our systems that can't exist.
Kudos. Yeah.
Thank you.
It is that dichotomy. It is that two-faced kind of thought, like, yes, we want to support you. And I would say that's not that far off from the United States in some of those regards, that, you know, we would check the box and say, do you want police call? Do you want to report this? You know, you're going to have to take time away from work to go to court. And because of their condition, it may not result in anything, but we're happy to support you doing that.
Mm-hmm.
That doesn't sound really supportive.
And it doesn't stop the violence. It doesn't stop the violence.
No. Yeah,
to me,
it's very reactionary.
To me, it's a distraction from the actual problem, which is that nursing professionalism is dead. And nobody knows how to teach. They're teaching theory. They're teaching concepts. They're building nurses that can start IVs, but they're not building nurses that can walk into a room and read a patient and be what the patient needs. That's a nurse. That's nursing, is to know if your personality does not match the personality of the patient, well, then it's better to just do your job and smile and walk out. Like, that's professionalism. Or if your personality does match and you are good with the patient, how do you foster those skills? And when you don't have those skills, maybe you're just an introvert and you're very smart and you're just not talkative, then what type of discipline is good for you? Are you better in the ICU where everyone's really sick and intubated and you just need to focus on getting things done? Then you are better in an environment where you have to talk to everybody. And that's part of nursing education, figuring out where those personas should fit so that our profession can build and can continue to be viable. And that's where we're not helping. We're just throwing nurses through. There's no delineation between mental health nurses, pediatric nurses, ICU nurses. You get dropped out and then you can pick a place, and that place is wherever you can get a job. And so you might not even like that environment. You might have hated it during clinical, but that's who's going to pay your bills that you have to pay off your $50,000 student loan, right? So you're going to be stuck there in an environment where nobody's really going to try and help you with your professionalism aspect. And there's old seasoned nurses are gone. So they can't help you because you watch by observation. I used to work with this nurse named, I'm not going to say her name, but I used to work with this nurse.
I was like,
wonderful. She was wonderful, and I used to pay her in honey buns because I used to piss her off when I would do dumb shit. And the intensivist would always yell at me, right? And so he'd be like, get somebody who knows what they're doing in here. And then I'm crying in the hallway, right? And so I at that time, she taught me, though, by watching her and interacting with patients, and she would critique my interaction and say, look, I know you were trying to be really upfront with the patient, but I could tell that they just weren't feeling that, and you need to step out and then come back in a little bit later and then have that conversation, or whatever the tip was. And now I'm seeing in the clinical and the actual bedside that nurse managers, these are young, and the people that they're picking to orient are also fairly new, and they're not going to the colleague and telling the colleague, hey, this is what you need to address. They're just going to the nurse manager's office and saying, little Katie over here just isn't getting it, and I don't know how to make her better. And so there's where leadership training and really valuing a type of training that we can talk about professionalism in that approach. And it might be as simple as saying, hey, you don't have to be overly bubbly if you don't feel that. But how do you still speak to someone with respect and professionalism? Because that type of culture is just lost on the new generation that's out there. There's 19, 20-year-old kids who just don't have the same sense of like respect and tone that we have. And it's not just tone, it's the ability to receive someone else's tone and figure out what to do with that after you've heard it.
In fairness to Generation Z, I've met some very rude 30, 40, 50 and 60-year-old nurses and doctors.
I was just going to say, I do see generational differences, but I also see people who are crusty and burnt out and really are just tired and shouldn't probably be working anymore, who also don't know how to communicate well.
Yeah.
Well, all the good nurses left. All the good nurses left because they couldn't help advocate for quality anymore. So as the for-profit...
Yeah, I think it's a complex issue. I mean, I think it's a variable issue in the sense that the training is different, right? People are getting kicked out of training. You know, I recently implemented some training. I partnered with a guy. His name is Stefan Baez. He's awesome. He comes from law enforcement and he has taught autism awareness and ASD, you know, people who are on the spectrum and how historically and statistically their interactions with police tend to be negative interactions and experiences. And he also has 2 children who are autistic, and he ended up developing a program and is nationally known for this and is fantastic. And I partnered with him and I created, you know, we trained all of our public safety teams.
That's so
this,
cool.
knowing
I remember that. That was neat.
People are coming in crisis, but you cannot respond and communicate the same way because of a varied number of reasons. I then in turn took that, and I had nursing coming to me saying, can we get some autism training? And I'm going, is that a clinical thing? Should I be the one teaching you that? You know, but I'm like, sure, no problem. And developed a program specific to, you know, ER, specific to critical care, specific to our adolescent behavioral health units or mental health units that is taking off like crazy because they're like, we've never even gotten basics on this before. And this is a huge part of our population. So and same doing that, then looking at those special, you know, situations or circumstances or subgroups, dementia patients. You can't go in and reason with a dementia patient the same way you would reason with somebody who's upset because of a care plan. You
Alcoholics,
just can't.
addicts.
Right. And so it's about critical thinking. It's about building things that are not common anymore. And I'm going to sound ancient in saying this because now I feel like, but look at how people grew up. I mean, we're so not in person and disconnected and social. You know, I know people who have never asked somebody out and had to feel the pressure of like being in front of somebody to actually get a negative feedback. Someone might say no. It's just swipe. Oh, you don't like me? Okay, no big deal. I don't actually have to deal with the negative interaction. Oh, now I'm embarrassed or now I'm angry or what? Like, how do I emotionally regulate myself? If
you should see me
had exposure.
You should see me trying to get these new nurses to call a doctor. Like dial the number and can I just text him? I'm like, no, you can't text him. This is important. They're like, but why can't we just text him? I'm like, because you need the order now. Like the patient is sick. Like we need to know what to, like, you have to do this right now. Like this isn't, and they're like, are you sure there's no other way? I'm like, it's a phone call.
Well, I mean, it's not to say it's all bad, right? Because technology has really enhanced so many things and really made us be able to connect in ways we would have never been connected. I wouldn't be sitting here with you guys today if we didn't have this platform, right?
Shout out to Riverside, the best podcasting platform ever.
We would never be able to connect in the ways that we are able to today without that technology, without those pieces. So I'm not against it by any means. But I think because communication has evolved some of the in-person basic skill set of having to communicate and assess behaviors. And, nurses are good assessors. They have to put pieces together, but they're looking for symptoms. If we do the same with behaviors, hey, what are some of the signs and symptoms you're seeing? What are some of the patterns? You should be able to kind of piece that together. Here's really how I need to respond, but I have to have some foundation for that.
Yeah. And you could definitely do that. You could even crudely apply, Pareto's theory about the 80-20 rule. So you could probably find that 80% of incidents have a 20% commonality. And that's a great place to start when you want a foundational understanding of something to do with risk or behavior or the interlink between mental health conditions and violence or just whatever. Like, yes, there will be outliers. Yes, there will be things, but it's this, we've got this miasma of chaos on one hand, and then we use that complexity to justify inaction or inactivity.
Yeah. That's what I'm going to ask you, Dean. This is my question I have to you. If you were part of a really innovative group of experts that wanted to benchmark data across the country for workplace violence, what would you suggest we did, knowing that there's research out there already that we could probably pull from? Yeah. What would be your next strategic approach as being someone who was up in the higher areas of these big universal systems of people that do that, accumulate data that way?
Yeah, and I think I lean more on the fact that I'm just a man first, which would be, why would I recreate what's already been done? And I'd cast my net wide to find high quality stuff and just do a very good reconnaissance about whether it's relatable. And if it was mostly relatable, then that would be enough. So I'd go to the Canadian, British, American, Australian systems where we have a commonality of either language, culture, or even constitutional delivery of healthcare in terms of how law and ethics broadly applies. Again, there will be outliers. I would then use that and take a look at, well, what was the methodology? And what's the thing we're trying to find out? And actually, does it give us wisdom without us having to repeat the process? So, and if I can use that, then that, and I would not repeat stuff. So if say, for example, there was a great study done in healthcare systems in the UK, let's say urban ERs, and we wanted to look at things like what was the rate of incidence of mental health conditions for assaults in A&E. I think you could probably use that with a high degree of confidence to at least answer a lot of questions about US similar cities. London and New York are much closer to one another in terms of how they function and who lives there than New York and LA. Yeah, similar sized populations. You've got every language spoken there. So if I were in New York, I would not frustrate myself waiting for information from Boulder, Colorado. I just wouldn't.
I think we're talking so much about data, right? Because it doesn't exist in the ways collectively that we're willing to share. It doesn't exist in the ways that we want to look at it with all of its capacity. And we don't want to just collect data, to your point, Dean. Don't collect numbers just to collect numbers. If it doesn't mean anything and you're not going to do anything with it. I think so. In my lifetime, I have seen all of healthcare. When I've been involved in healthcare for over 25 years, really since I was like 16 years old. So I won't tell you all of that math. But that being said, give it away, right? I can't give it all away. So, but the reality is we need to change from a reactive approach to a proactive approach, to a preventative approach. And the same stuff that we've done forever is not working. And we're seeing it exponentially get worse. So how do we innovate, and how do we partner and start sharing? And to your point, look at what's already been done that is valuable and valid and credentialed that we could pull in and look at all these people with great experiences and say, this is what's working and let's build.
And to me,
I think so. I think I used to get Sorry, Mel, go ahead.
I was just going to say really quickly, from a business perspective, to me, it's like businesses are spending money on these big tech companies and people that I believe in tech and innovation. Everybody knows that. Mel's all about that. But I don't want them to be spending all of their budget to try and bring that stuff in and then not actually make a difference because they didn't fix the core problem, which is staff training and like what's next to the asset. Anyway, go ahead, Dean.
Yeah. No, that you've actually just made my point for me. And I suppose, trying to bring this back into a less philosophical academic application. So let's say, for argument's sake, let's say if Kim was kind enough to invite me to visit her systems, and I'd happily go. We'd have a look around. I would hope.
You have a standing invitation.
Thank you. And I'm happy to take it.
Let's go.
Yeah, but last time I was there, I was in Wicker Park, and I had a great time. So I'm happy to go back at any time. Yeah, really. Which part of the day?
That pause tells you.
Yeah,
the pause gave it away.
I mean, it was before I was married, and it was 2013, so it was a long time ago. But I would hope that, let's say, for argument's sake, Kim said, "Oh, could you just have a quick look at our behavioural health unit? I know you've worked in, read about, written about, managed these services." I would like to think that after 30 minutes, maybe a little bit of conversation with staff, some observation, Kim would probably express her priorities. I think it would be in bad faith if I said, "You know what, Kim, if we commit ourselves to the next 15 years of data gathering and analysis, we might be able to improve this service." Like, what are we doing here? Like,
that feels terrible. Yeah.
I always used to say to my staff, we'd have this big problem. I was like, let's be the data we want to see in the world. Let's try something, measure it, and then tweak it as we go. Come on, let's get stuff done.
I think, we're stagnant, right? And it's an act of Congress to get something to change, especially when, more and more healthcare systems can't run independently. You're not as nimble. You can't change or flex as much. A lot of healthcare organizations are merging or takeovers or, are operating for financial purposes, much larger levels now. And you lose a little bit of that ability to just flex right away or be the decision maker without having to run it up 5 different levels.
What's your advice, both of you? I'm going to ask you your advice because this is conversations that I get all the time. Is security director calls me and says, "Mel, somebody just got shot last week. What do we do?" And I'm like, "Okay, well, you should have called me before last week so nobody got shot." But anyway, I want to hear from both of you. If you are security director, Mel's a security director. Hi, I need something. I think I need something.
What help us?
What?
You do, Mel. You definitely need something. My professional opinion is that you do. Quite what? I'm not going to say on this podcast, but yes, quite right.
We were doing so well. It was going pretty
professionally. I need Haldol. I am. No, I'm just kidding. But anyway, that's my. Tell us what you would do. Kim, what's your recommendation? Dean, what's your recommendation to someone that wants to get things done within their organization and feel like they're up against the mammoth of the system and they're not sure how to navigate that?
So I kind of have a specific answer to your specific question and then maybe a little more global. In that circumstance, one of the things, we have to learn everything we can about it. So one of the things I think we don't do well is debriefing, is really after action planning. I come from emergency management. I come from emergency background, all of those things. And that is a key indicator, a key opportunity to really take a deeper dive and see where all the pieces lined up that this became, the Swiss cheese of, if it was going to go wrong, it went wrong. Here we go. What were missed opportunities? Where did the process break down? Not looking to blame. I think, especially our staff nurses hate debriefing. Public safety hates it. No one knows how to actually facilitate a debriefing in a way that everyone leaves feeling, hey, okay, that made sense, or I learned something, or I know what to strengthen next time, without it feeling blamey or judgy or what could you have done
Would you
different or
pay,
why did this happen?
if it was cost effective, would you pay a third party like organization that you had a good relationship with, like a clinical investigation company or something, to come in and do a debrief of an incident that you had, and to get a professional opinion that's not like someone who's a nurse but not part of that organization, who's contracted to come in and gather data for you, like say like an exit interview, but instead of the exit interview it'd be a debrief, like, you know, what happened in this scenario. You're not talking to your clinical manager, like, talk to me as a nurse, tell me what happened and how you felt. Like, do you think there would be added value in having an independent person come in and gather that data and then give you a report where you're separating the employee from making them feel like there's blame? Because sometimes that works well in exit interviews.
Yeah, I see your point. Yeah, and people don't want to hear me all the time, right? Because if they're sometimes it takes somebody else to say it. My officers do that as well. You know, they would go tell somebody, "Hey, here's our visiting hours or our guidelines. You can't do this," and they raise holy heck, and they want to talk to a manager, and I come and say the exact same thing, and then they listen, and they're like, "I just said that." I'm like, "I know. It just took another person to reinforce the idea." So sometimes outside contractors, outside consultants are great because they make people like executives listen when they know your voice, they know your opinion, but they want to validate that with an outside unattached perspective, right? So there's real value in that. But I also think that there's a variety of ways to approach that. You know, there are different types of debriefings. So if you're looking at like a CISM or CISD, a critical incident stress debriefing, which is more about the well-being of the individual, how they're coping with it, how they're managing day to day, how they're feeling after processing the trauma or the incident. And that's done periodically or at a variety of times. That's very different than an operational debriefing and very different than an outcome review. So I think that those three layers, what's your purpose? You know, and I always would go back to a risk assessment, a threat assessment, a hazard assessment. What are the things we can affect and impact that are immediate, quick wins, and low cost, right? So that people, so I always say there's two types of security. One is the actual physical security, and one is the psychological security or safety, right? There's physical safety, psychological safety. I could be in Fort Knox and secured to the nines and still feel unsafe, right? So we have to address both parts of that. Where was the actual breakdown, and how do we train, empower, support our teams so that they don't like, oh, I have to have security here to manage this.
Yep.
No,
Yep.
you have the skill to do this as well. So, you know, I think it's got to be, I keep saying this, but a varied approach. You have to hit it from a couple of angles. There is no one solution. It's a complex problem. And I think more and more as we peel back the layers, we start seeing, why is it so prevalent in healthcare? Why is this such a problem? Because there's not one clear-cut answer, and you're talking about a large, diverse, you know, population.
Yeah. So go ahead, Dean.
Yeah. I mean, I'm equally gonna frustrate the people that want the silver bullet solution, you know. And going back to your question, because I agree with everything Kim has said there, and my approach is that quite often I think we get hung up, particularly if you work in an organization where over here we refer to it as QI, quality improvement project. It's a whole methodology and it's a whole approach. If you're in an organization where QI almost becomes its own subcult, you don't actually really improve things, but you're always working on things. And I think people become preoccupied with the idea or the tech or the thing, rather than actually you need to invest time to make sure you have alignment. So I a few years ago I wrote, and as far as I know, I invented it, but who knows whoever invents anything anymore. I called it the 4 dimensions of leadership, because you have to be able to lead up the chain, down the chain, laterally, and you have to be able to lead yourself. Well, all of your time needs to be spent doing that, all those 4 things really well, to have alignment so that any idea has any chance of being successfully implemented. So if you don't have the support of whoever you report to, it doesn't matter if you've just cured cancer, because someone's going to sabotage it or ignore it or not give it the resource that it deserves. If you don't take the group of people reporting to you with you on that journey, they're going to leave you at the first sign of adversity and nothing's going to get done. So to me, Kim alluded to this earlier, healthcare is the ultimate team sport. I really believe that. And it only works when you've got alignment across all the people, and everyone matters. And the truth is that everyone really is the most important person in a healthcare system. Because if you want to try and run a healthcare system poorly, dismiss all of the domestic staff, the porters, the cooks, cleaners, doesn't matter how many nurses and doctors you have, your system just will not work.
And I like that you said over time, right? Alignment, but over time. I think going back to Mel's question, that incident fosters immediate attention and immediate knee-jerk reactions. And then you get places that are, buying a weapon detection system for one door and putting it in a closet because they haven't operationalized the staffing to understand how it works. But hey, everyone, we bought it.
That's fine.
Right. And
People
you're like, that
$100,000
was pointless.
Mm-hmm.
And
you
so
must see that all the time, Kim. Like this cognitive dissonance, but it's such a overreaction that actually doesn't solve or address the thing.
It's
you
frustrating.
Must see it. Yeah.
And you can't dismiss it because it's an opportunity.
Yes.
People are seeking.
Yes.
People are seeking safety. People are seeking solutions.
Yep.
And if you dismiss them and go, okay, you're going about this all wrong, or you're just reacting, which, yeah, that's part of it. But we have to step back. And again, I believe going back to the fundamentals and the basics. And yes, we have to do maybe there's more urgency now, right? Maybe there's some more attention on it. We have to capitalize on those opportunities. Unfortunately, as I've said, it's a reactive industry. You get a lot, security gets cut. And then, oh my God, a situation happens. Here's all the budget. Do whatever you need. Because we have to save the reputation. We have to save the staff.
Thin air. It just fell out of thin air. So
it just got prioritized differently.
Well, because
right?
they don't understand the need. I truly believe that anybody who's running an executive board, maybe short of our yacht friend, they're pretty much, they're ready to do something impactful, right? And most of the team wants to be there and they want to be helpful and they want to build an organization that's profitable and delivers quality care and their face is on a billboard and all that shit. So I think you have to learn how to figure out what their issues are. If your organization is hemorrhaging nurses and every time you go to a work board meeting or an executive meeting and they're talking about we need more nurses and we don't have enough staff and blah blah blah, then that's kind of where you target your next RFP, right? Like, okay, let me figure out if you want to do a weapons detection system, what's something that's going to help retain staff? Well, let's put a survey on the side of the weapons detection system that nurses can do a QR code and do a survey about how safe they physically feel. Or let's do some training when the weapons detection system comes out. Like, hey, everybody, we invested in this, but here's a training suite that we developed to talk to you about what to do if there is an active shooter or whatever the concern is that you're bringing in, that technology innovation, And that's what, to me, and the opportunity that exists with technology is to piggyback the asset benefits, the training, the professionalism, the conversations that, hey, don't leave. We need you to help this situation. Like, you have to, if you want to be a nurse and you just spent all that time going through school or to be a doctor, what are ways that you can help with this? How do you advocate professionally? How do you, if your incident reporting system is too laborious and too hard to use, then make that suggestion. Like, what is hard about it? Tell that to the security director. Don't just say it's too hard and I don't have the time. Be like, this is the actual problem, why, and come to them with some solutions so that people that are innovative like Kim and like Dean can say, hey, I heard this from a staff member and we should try it. And I think that's the portion, is like, we need to start trying stuff instead of talking about wouldn't it be nice if nobody hit each other anymore?
I think it's really crucial for that holistic approach to occur, right? It's going back to making sure what is the end point, because honestly, I've been really blessed with executives that have always supported public safety. And I know that hasn't existed in lots of organizations. And even more so now, I'll come up with crazy ideas or say, every single nurse needs to be trained on something, or, and from my AVP and my CNOs, and, one of my CNOs literally said, this is just the cost of doing business. We have to figure it out. It's required
Good
for
for
staff
her or
safety.
him. That's a great comment.
Yay. Yeah. I mean, and so it's like, okay, no, this is a non-negotiable. It's really the message it sends. And so I think it's really understanding the numbers, really understanding the need, really understanding how it is overall beneficial to some of those other deficits and things that people have. And I would highly encourage people, I mean, just all the conversation we're having, it's complex. You don't have to know it all. You don't have to know the next steps. Ask somebody. Don't be afraid to, I'm not going to tell you how to run your, open heart procedure. I know some of the steps that you're going to do next, but I don't know how to do it. That's your expertise. So as Dean mentioned, right, healthcare is a team sport. It's a team approach. If you don't know, reach, because it's out there. Now we're creating solutions. Now we have organizations.
Yeah, go get
Now we have
Kim
data.
invented this incredible software where all you literally have to do is sign up and answer the shit, and she'll build you a workplace violence prevention program. So if you need, and I've looked at it, and I critique everything. I rarely like stuff that's not mine, let's be honest. Like, I mean, I wouldn't be a founder if I did it. So I like Kim's platform from what I could see, and I'm happy to say that it's definitely needed for like someone who is trying to own a security department in a rural community hospital with no support, and or maybe a workplace violence prevention committee that has to get off the ground shortly in order to make legislation or to meet recommendations. They just don't have the budget, they don't have the operational time to pull together. Utilizing something like Kim's invention, where she's taken all of the best practices from her experience and allowed an assessment to go through the organization and figure out where your gaps are and what you need, is essentially so important to formulating what I'm trying to do, right? Creating a standard approach with which we have to at least meet, so that we know our nurses and our staff are going to be protected in the way that we've at least established to try to create a baseline. If we exceed that, even better.
Thank you for that. Yeah.
I think that's it. Sorry, Kim, go ahead.
No. I was going to say, I think it's not a one size fits all. That's the problem. And people come in with one mindset. Well, the hospital mindset doesn't fit the mental health center, and it doesn't fit the doctor's office, and it doesn't fit the surgery center standalone ER or any of those other pieces. And so it's really about customization. And so I'm really excited about it. And I think it would be, and it's specific to what state you're in and legislation. It's specific to what your area of service line is, right? So based on what risk comes along with some of those service lines, it does it all for you and takes the time out. I think the real gold is the gap analysis, though.
Yes.
Maybe we don't have $40,000 to hire the consultants or hire us to come for a week and physically be on site and do everything. This is kind of a DIY, a do-it-yourself, but from the experts, right? From the consultants who would be doing it with you, where you can really get a huge jump and get that gap analysis. So you know what to prioritize. So you know what budgeting to do for the next year, 2 years, 3 years, 5 years. So you know what is the priority for staffing and keeping it. So yeah. I'm looking forward to getting a beta group, and piloting it and
Oh my God, yes. If
all
you are
that kind of
interested in
stuff.
piloting Kimberly Urbanek's beautiful,
Yeah.
conceptual, amazing platform, please reach out to us. We will drop
Thanks.
her email and information in the show notes below because I think it's a win-win. I hate people who say win-win. I can't believe I just said that.
You've become everything you hate, Mel Cortez. This is the moment. But this is what I was going to say. What a great place to wrap up in terms of, because Kim, I don't know if you know, but people that come on our podcast and are generous enough with their time and their expertise and insights. Well, it's not an entirely altruistic experience because, man, I think it's fair to say that our people, they get a little bit of a podcast bump, right? I spoke to Andy Mannix the other day. He'd been on the podcast. He's very happy. I think overall it's certainly Ari Brenner. You may remember
35% increase in engagement. And yeah.
So it would be remiss of me if we didn't allow Kim the opportunity, if she would like to take it, to say where people can find her, anything she wants to promote. Fill your boots, Kim, anything you want.
Wow.
The floor is yours to tell people how to get in touch.
Yeah, I would love to connect with anyone. I'm really passionate about helping make it better, right? Just making it safe, working through training, customization, so it's practical and approachable and cost effective, working within your means. So reach out to me on LinkedIn or on any sort of social media. It's under my name, or on my email. It's Workplace Violence Prevention Strategies. So it's
we'll put it in the show notes.
WPVP
Yeah.
at
We'll put it all up.
strategies@gmail.com.
Yep.
Great.
Brilliant.
So
it's always fun to chat with you guys. It's always a blast.
Let's plan how we're going to take Dean to Chicago.
When are you coming to Chicago?
Let's take Dean to Chicago.
I was looking for flights. Yeah, I'm all in. Yeah, I'm ready.
Well,
Dean, I told Dean I would get him a ride along if he comes to Chicago.
Yeah, I'll do it. I mean, now I've thrown caution to the wind. I'll go. I've become that person now.
Not
Go on, Mel.
that you would even know, Dean. If I hadn't introduced you and no one's offered to bring me on a ride along, I wonder why.
I can be trusted to not misrepresent the police forces amongst the criminal underworld.
I'd be like,
maybe the same can't be said for you.
I'll be like, what do you think they're
I think
selling
his
over
accent,
there?
His accent may calm situations.
See?
I'll be like, what do you think they're selling over there? Do you think we can get in on that?
Yeah, and I've seen The Wire, Mel. By contrast, people in Baltimore not known at De-escalation, so I think Kim's quite wise. I think she's selected wisely here, to be honest.
How do you think I'm so involved with use of force, right? I'm like, look, I got a little bit of backtracking to do there.
Yeah. Well, we call it use of force. You just call it life. I mean, that's just where we're at, isn't it?
Look, either you want to come see a Ravens game or you don't.
To Mel.
Okay?
It's just a Tuesday. We love
I'll go when the Bills are in town. Yeah. This is really Mel's support sessions.
Thank you for how much do I owe both of you? I'll bill you. You bill me.
It's immeasurable. Get us out of here. Wrap us up.
Dean's keeping the tally, though. I think he's keeping the tally. One day you're going to be shocked.
I know. One day.
Got a notepad just there. Yeah. No.
All right, guys. Well, thank you so much. It's been another awesome episode of Tactical Scrubs, and I look forward to us catching up. And stay tuned. Maybe we'll do Tactical Scrubs live from Chicago after Dean has an experience on the L.
Sounds good.